right, so this is another edition of Off the Cuff Nurses, and I am Dr. Minter. I'm a nurse practitioner, and I've got Dr. McConnell, who's a physician and medical director, and I've got PA Henderson, and we're going to talk about correctional medicine. So today we're going to talk about chest pain, not our chest pain, but chest pain when we run across patients in jail. And we're going to stay up front that we're not going to constitute this as medical advice, but we want to give an overview as to what happens in jail. We run into a lot of chest pain patients, like every day.
Yep.
All day.
Multiple times a day.
Multiple.
Sometimes from the same patient twice a day.
Yeah, right. So let's go into, so you've been quiet, PA Henderson.
Yep.
So give us a typical patient you'll run across.
With chest pain.
Yeah, with chest pain.
I would say it's quite variable, but most commonly, I think the patients that come in that have complaints of chest pain don't have a cardiac-related chest pain. The problem is, how do you ferret out which ones don't and which ones do?
So how do you do that?
Start with the examination, conversation. I'm trying to talk to the patient, trying to see how they feel. Good examination, especially heart in particular, lungs. But we do an EKG commonly. Sometimes we'll get labs if need be. That's kind of the starting point for me.
Okay.
I would say, and I don't know how you feel in the ER or yourself, I think that generally when I walk in and see a patient, I can probably tell you pretty quickly whether they're actually having a cardiac problem for the most part. Not always, because there's definitely some patients that come in that look fairly good and their heart is not doing well. But generally if they come in and they're like, hey, I just got through eating, I laid down right after I ate, I'm starting to have some chest pain, and they're talking, acting completely normal other than just the complaint of chest pain, generally that patient's actually going to be doing pretty good, generally speaking. But we do the same process regardless of whether I think they're going to be doing good or not. We still do the same thing, still do the exam, still do the interview, generally get an EKG. But yeah, generally those patients are doing pretty well.
When we say chest pain, we're usually concerned with the heart, but there's other things outside of the heart that we worry about with chest pain, aortic dissection or something like that, other stuff to consider. But probably the most common cause for chest pain is either anxiety, especially in the jail setting, if it's particularly somebody young. The other biggest thing is going to be GERD, gastric reflux, or esophagitis, things like that.
Because the food is so good.
Yeah. And I think it's all the commissary. A lot of these guys and gals
100%.
just love to wolf down.
Yep.
But yeah, as PA Henderson said, starting with that initial physical exam and conversation you have is going to help a lot. Looking at...
Like what? Like what... Explain to people, like, what do you call an initial conversation?
So initial conversation, you want to get what we call it's old carts, I think is, if I'm right, the acronym: onset, location, duration, character, aggravating, alleviating, radiating, and temporal. So you're looking at all of the things about the pain. So when did that pain start? What does it feel like? How long does it last when you have it? Does it go anywhere? Have you noticed anything that makes it feel better or worse? All of those types of questions. That's asking about the pain itself. The person who comes in and goes, oh, I have a chest pain and it feels like somebody's poking me in the chest right there, and it lasts like a second and then it goes away, but then it comes back. And I'm probably almost definitely not cardiac, which is our big thing we worry about because that's what's going to kill you the fastest. And then you try to figure out, okay, is this something else? Is it pulmonary embolism, which is in the lungs, which can cause chest pain? That's a different type of pain. Most of the people who have that type of pain, they're going to complain of a sharp and stabbing pain. They're not going to complain of a burning pressure, usually. So you're asking those types of questions. Does the pain go anywhere? They go, oh, yeah, it really starts to bother me. And it lasts maybe 20, 30 minutes, and my right shoulder aches, and I move my arm, and that doesn't seem to make it feel any better, and if I burp a few times, and it helps, but it's still there, and then it kind of goes away. I'm starting to get a little more worried about that guy. Now, if he's 21 and telling me that, less worried. If he's 61 and telling me that, way more worried. Mm-hmm. So first you get that character of the pain. What is it like, and all the stuff around it. What were you doing when it started? Was I working out in the gym? Were you fighting somebody? Were you arguing with the corrections officer? Were you sitting there on your bunk reading a book?
Did you just come back from court?
Yep. Did you just come back from court?
Yeah.
Then you're going to look at things like the vitals. What is their blood pressure? Their blood pressure of 120 over 80, that's awesome. Blood pressure of 200 over 80, not so good. Mm-hmm. Blood pressure of 80 over nothing, you're like, oh, that's really bad. So you're going to look at those things, the vitals. That's why we harp all the time when we ask the nurses, make sure we get the vitals, make sure the vitals are in the record, because we want to be able to see that. Those are important. That's why they call them vital signs. They're vitally important. And, they do a good job of getting that stuff in there, and we see it. After that, then you want to start looking at the other things around it. Well, what's your family history? This guy's 50. Do you have any family that's ever had a heart attack? First degree relatives, mom, dad, brothers, sisters? And well, my dad died, and he just fell over dead at work at 48, and I don't know much about my mom. Both my brothers have had heart attacks. One of them just had that one where they did the thing and opened his chest. Well, how old is he? He's only like 42. He's my younger brother. Right away, I'm like, okay, now I'm really worried, Or if they go, oh, man, everybody in my family lives to 100 and nobody's ever had anything with their heart. Again, less worried. It's all trying to narrow down, I won't say risk mitigation, but, where do you want to go with that? How concerned should you be? And that's when you start looking at, do I need EKG? Do I need labs? The guy with 1 second of chest pain who's 21 years old, I would not get an EKG on that guy, most likely. If it's available, I know that you had said that some facilities don't have EKGs, so, they don't have a choice. It's not available to them. If it's available, no harm in getting it, as long as you have somebody around who can interpret it. But I'm not going to send a troponin, the lab for the heart on that guy. That guy who's telling me he's 50 and has a strong family history of it, definitely getting an EKG on that guy. And that's where it becomes important to look at the historical stuff. One of the big issues we have in jails, a lot of times there's no history on the guy. But we do tend to have some repeat customers who come back from time to time. So sometimes you can look in the chart and see, do they have an old EKG? Do they have old labs? And then you can start comparing, well, what do I have now compared to what it looked like? You look at their EKG and it looks okay, and you look at their last one, it looked okay, and less worrisome. The thing to remember with the EKG is I tell people it's a snapshot in time. It's a photograph.
Right.
If I get a good EKG on you right now, and 2 minutes from now you start to have a heart attack, that EKG did not tell me that was going to happen.
Right.
It can tell me you had a heart attack in the past. If it was a big enough one, what we call cued out, where the waves, you get the Q waves in there. And it is best at telling me if you're possibly actively having one, what we call the STEMI, the ST elevation MI, which is the heart attack you can see on the EKG, as opposed to what we call the NSTEMI, meaning the non-ST elevation, meaning that when you look at the EKG, it looks okay, but when you get those labs come back sky high.
You mean like a partial occlusion versus a complete occlusion?
A complete occlusion is most likely to give you the STEMI, but a
Right.
partial occlusion can do it also. I would not be confident enough to go down the road and say that one will give you one or the other, because you can have a complete occlusion of a very distal artery, which will give you an NSTEMI, despite the fact it's a complete occlusion. It's just so far down that artery. Or there may be so much what we call bridging vessels, somebody who has so much additional blood flow to the heart that it even though it's a complete occlusion, it doesn't show up.
Yeah. Collateral.
A collateral
is what we
circulation.
call it.
Something you touched on was kind of poking into the chart. I'm a huge fan of that. I try to, as they're bringing the patient in, I'm trying to get their name so I can pull the chart up, reviewing not only previous EKGs, but previous complaints. If this is something they have an issue with constantly, has it been something legitimate? Do they have cardiac history? Or is it something where they just come down because they want to get away from their pod? Again, kind of going back to something from previous episodes we talked about, it is challenging in this setting to ferret out what is their end goal? What is the patient's end goal? Do they truly have chest pain, or do they just literally need to get out of the pod?
We have the one gentleman who's, I believe, 42. He's in his 30s. He's had 40-something EKGs in the last 6 months. He's had a cardiac cath and everything, and all of that is normal. The probability that guy has a heart attack in the next 10 years is infinitely small.
Yeah.
Never zero, but incredibly small. So anytime he comes in complaining of chest pain, you're like, okay, this is anxiety. Just like I told you yesterday and the day before and the day before. The important thing with those guys or gals is if it's your frequent flyer that always comes in complaining of chest pain, and they come in one day with a new chest pain story, all of a sudden everything has changed. The way they're describing it has changed. Maybe they got coached by another inmate. Maybe something's actually happening now. That's when you definitely want to start thinking, this is not his usual story that he tells me. He's now describing something that sounds more concerning. I definitely don't want to blow this guy off now.
Yeah, those are the patients I think can be the most challenging, because you don't want the boy that cries wolf mentality, and you do just blow them off, and it turns out to not be something that needs to be blown off.
Yeah.
But yeah, to your point earlier, like how do you start that evaluation? Certainly talking to the patient, evaluate the patient, but I do go into the chart quite a bit. I like to see their previous history, especially with those EKGs, or if they're just common complaints. And you kind of know, when you work in the same facility for a while, you kind of know these patients pretty well at some point in time. You know when they come down and they're just feeding you their normal line and everything's okay. Their behavior is perfectly normal for them. Those are patients that I certainly do the exam, but I don't know if I go the full out, like labs, EKGs, all that stuff.
Yeah, and one of the things that I do is more so in prison, but when I was working in prison, to try to get historical information on them. I had a guy who was a young guy, he was like in his 20s, and he came in for something unrelated, and I don't know what. And then I listened to his heart. I mean, all you heard was murmur. You didn't hear anything but the murmur. That's all you heard. And so I was like, "Do you get some chest pain?" He's like, "Yeah, sometimes." So I got the medical director, who was a cardiothoracic surgeon, and he said, "Are you short of breath?" He's like, "Well, I don't know. I mean," he's like, "Well, how far can you run?" Or what? Well, what was normal to that kid was not normal. Like, he couldn't run at all, but that was normal to him. So what I asked him, I said, "Well, who raised you?" Because I wanted to know, did he have a stable parent? Because a lot of those guys didn't, or was he in foster, or did his 90-year-old grandmother raise him? And so he did not have a stable upbringing. So he never saw a cardiologist, and we knew he had some huge valvular issue. So we ordered an echo, and he refused the echo. And we ordered it again, and he refused it again. He just didn't want, and he just didn't want anything to do with it. But I usually say, who raised you? If it's a younger guy, and to try to get some sort of cardiac history on them, because you don't know. I mean, we had one guy, and he's like, "I don't know. They went in and they did something." Well, so the medical director, the same one, he did a chest X-ray, and there was all these wires all over the place. And I said, What is that? What's wrong? He's like, hell if I know. I don't know.
He had no clue.
He was like, I don't know. He just like, there were so many wires and stuff. So
the guy who says he's healthy as a horse, and you see the zipper already, and you're like, which horse?
Right. So try to get a background on them as to what they've done, and the historical chart.
Yeah.
Or the outside medical records.
The big thing, what's helpful to know at our level, is knowing the different decision-making matrices you can use. You've got the heart score, if you have troponin and stuff like that available, which kind of risk stratifies somebody's probability of having an acute coronary event within the next brief time period. And looking at something like that to determine, like, is this somebody who really needs to be sent out right away, or is this something that we can do with our outpatient cardiology evaluations and whatnot? So don't be afraid to pull up those risk stratification scores and look at those. Same thing for pulmonary embolisms. You have the PERC score or Wells criteria, which are different criteria that people can use typically in the emergency department, but we can use it where we're at also. If we're worried somebody comes in describing something that sounds kind of like a pulmonary embolism, but everything on them, what we call PERCs out, meaning that they made it through that whole risk matrix with no numbers, you're probably not real worried about it.
Or it could be something else too. I had a guy, they called me to see ways back for chest pain, but he wound up having a perforated ulcer, which was causing the chest pain.
Right.
So that you wouldn't want to treat that with nitroglycerin, because that would drop his blood pressure. So, and then sometimes too, if they're having chest pain, which seems like it's cardiac, if you give them a nitroglycerin, if it goes away, it's kind of, in some ways, diagnostic. What?
You can also use nitroglycerin for diffuse esophageal spasm. But yeah, if chest pain goes away with nitroglycerin, that definitely should raise your concern that this could be something cardiac related.
So what else do we do? So we do an EKG if we have one available. Some of the smaller jails in the country don't have those available, so they have to do some more physical exam skills.
We also do everyone's favorite of the blood pressure, checking that, because that's what ends up a lot of people in our awareness. Somebody gets a blood pressure of, it's sky high, what do we do?
So what do we do?
Well, That depends. It used to be, there used to be this thought that you should run in and treat blood pressure and get it down as fast as you can, regardless of what's going on. And then some people did some studies and found out that, hey, you actually give people strokes. I tell people when they come to the ER, it drives me nuts in the emergency department. They'll come in. I'm like, well, what are you here for? Oh, I was at the urgent care, and they told me.
It was at Henderson's
I sent them over there.
care, right?
I saw this guy, PA Henderson. He told me that my blood pressure was stroke pressure, and I had to come straight to the ER. And I check, and I'm like, oh, your blood pressure is 190 over 110. That is not good. I certainly don't like to see that. But, well, what are your symptoms? I feel great. Well, why were you at the urgent care? Oh, I got my blood pressure checked at one of those machines at Walmart, and it was high, so I was worried, so I went to the urgent care. I'm like, okay. I'm like, well, have you ever had problems with blood pressure before? No. So when I hear that, this person's got a high blood pressure, 190, 200, 210, whatever. It's high, but if they don't have any symptoms, you don't need to immediately do anything. And I tell them, I'm like, look, here's the deal. Because a lot of times people get very angry when they come to the emergency room, and I tell them we're not going to do anything. Because they want something done. They're here. Yep. They're like, well, I'm paying the bill. I want you to do something. Give me my Z-Pack and steroids,
For my blood pressure.
Right. Give me something for my blood pressure.
Yep.
I need it to come down. Like, look, and I tell them, like, here's the deal, sir. There is no such thing as stroke blood pressure. There is no such thing as heart attack blood pressure. There is high blood pressure. They used to have hypertensive emergency, but now they've done away with that term. They go with hypertensive urgency. But we look at the symptoms. If you don't have any symptoms, the goal is to slowly bring it down. I said, because here's the deal. Let's say your blood pressure is 200 over 100, and I give you medicines to make your blood pressure 120 over 80 an hour from now. That's beautiful. It looks so pretty on the monitor. Now, your blood pressure might have been 200 for the last 5 years. I have no idea. And your brain has never functioned on 120 over 80 before.
Yeah.
And your brain is not going to function on 120 over 80. So you came here worried about a stroke and demanded that I give you one.
Yeah.
And I tell them, if I remember right from the study that I read, the risk if somebody has a hypertensive related stroke is less than 1% if it's untreated. And it's 3% if it's emergently treated with IV meds. It's less than 3%, but still higher than 1% or less than 1% if it's treated with oral meds to emergently bring that blood pressure down if they are not experiencing symptoms.
Mm-hmm. What do you call symptoms?
Sudden onset headache, visual changes, chest pain is going to be the big one that we've talked about with this,
Right.
Because again, chest pain could be the heart, could be the aorta. If they're having an aortic dissection, the high blood pressure is not good. You need to drop it, but, rapidly and controlled. That's something that needs to go straight to the ER. We're not going to handle that at the jail.
Right.
I think people generally feel pretty poor when you push their pressure down too fast, too. They just feel bad. They don't. Like you said, they've been running high for years.
Yeah, we have no idea.
And you mentioned it previously. It's the silent killer. They don't even know what's going on. They may have a little headache every here and there, but generally they feel bad when you push them low. You push them low fast.
Yeah, and that's the important thing to remember. The biggest thing with blood pressure is there is no such thing as a number that's so high it must be immediately treated. If there are no symptoms, it does not need immediate IV oral big time drug intervention. That doesn't mean you're not going to immediately start them on blood pressure medicines. Mm-hmm. If you come in if I see you with a 210 over 110 and you don't have any symptoms, I'm going to start you on at least 10 of amlodipine, because with amlodipine, you don't need to get labs. You don't need to know their kidney function. You don't need an EKG. It's a safe medicine that you can give them without doing any other workup right away.
Cheap.
And cheap. We like that.
Yeah.
And it's effective, and that will help start bringing their blood pressure down.
Right.
And I say, here's the deal, I'm going to get your blood pressure. I'm going to start you on this new med. In the jail, I'm like, here's the deal. I'm going to start you on this new med. We're going to get you some blood pressure checks. Try not to refuse those if you don't mind. And as long as your blood pressure is coming down, we'll see you back in clinic in a month. Mm-hmm. Or say like they're not sky high. Say they're only in 160s or something. We'll get you some blood pressure medicine. We'll bring you back in 2 months or 3 months or whenever you need to come back in. It doesn't have to be next week or tomorrow or whatever. We want to give time for that medicine to be effective and see where you live.
And one of the things that in jail that's kind of unique is, you might have a little meth added in there. When they come in, if they've got methamphetamines on board, that could also increase their blood pressure. Yeah. Maybe wait for them to coast off of whatever recreational.
Well, that's one of the things that you'll see me say sometimes in the emails and whatnot. They get somebody who comes in, they're withdrawing. Well, one of the things that happens sometimes when people withdraw is their blood pressure goes up temporarily.
Mm-hmm. Right.
That doesn't mean they have hypertension and we need to start them on all these meds, because a week from now, 2 weeks from now, their blood pressure is going to be right back to normal. So if they were, 140s when they came in and they go up to 160 temporarily, well, we check them. We don't just ignore them. We don't have that deliberate indifference. We want to make sure that they're being evaluated, but I also don't want to start them on a medication that they don't necessarily need.
Right.
A friend of mine who had been on multiple blood pressure medicines recently lost a whole lot of weight. And when I was talking to him on our recent trip, he's like, yeah, man, I just feel bad all the time. I get dizzy when I stand up. I have all these issues. And where's your blood pressure? And I was like 100 over something all the time. Like, dude, you need to stop taking some of these meds.
Right.
When you were 280 pounds, yeah. But now you're 220 pounds. You've lost 60 pounds in the last year. Those meds are now too strong for you.
Right.
And when I talked to him the other night, he said, hey, I quit taking the carvedilol, his beta blocker. He said, man, I feel so much better. My blood pressure now is 120 over 80. I'm not dizzy anymore. I don't just feel nauseous and run down nonstop. This guy was over-medicated on a medicine he didn't need anymore.
Right. Every pound you drop, if you're overweight, can drop your blood pressure by about a half to 1 point. So you have to adjust it and go back.
And I think that's super important, especially in correctional setting, is a lot of these people come in, they haven't had treatment on the outside, they're worried about their pressure, and they think they need to get medicines immediately, but they don't really, just because they're unaware and maybe uneducated on it, they don't realize that no medicines are given in a vacuum.
Right.
There's always these potential negatives that come along with any medication. The example I tell patients kind of goes back to something you previously said about, like, everybody wants an antibiotic, is everything has a negative, even water. We all know we should drink more water, but if I hold somebody's head under the water, that's a little too much water. And so it's like everything has some kind of consequence. It's a trade. These medicines are a trade, a balancing act. What do I get? What do I have to give? And sometimes the give is a little bit more than it's worth to drop somebody from 145 down to 135.
Sure.
Yeah, especially, like I said, if they're asymptomatic, it's not a rush. There's no harm in bringing it down too slowly, by and large.
So when you're evaluating chest pain and somebody comes in and their pressure is elevated, but also their pulse is elevated, which thing gets you the most concern? The pulse or the pressure?
Probably the pulse.
Me too. That's a little more scary, I think, when somebody's like tachycardic, for instance.
Yeah, I want to see what's going on with the EKG.
Yep. And that's kind of going back to the vitals. We're definitely looking at those, and the pressure comes in, and then when the pulse is elevated, I'm probably jumping a little faster up to go see that patient than I would be if it was just an elevated blood pressure.
Plus, if it's irregular.
Yeah, for me, it would be the thing I'd be most concerned about is how fast is the pulse, and what's the regularity? Is it is it regular rhythm, just a high rate? A little less concerned than an irregular rhythm. And if you tell me it's 150, or machine says 200, like the 133, 150, 200 things that tell me it could be AFib with a block, because they tend to sort out into those numbers. You hear those numbers all the time. Somebody comes in at the pulse of 105. I myself would be a little less worried if they're saying chest pain. I would also be wanting to look at the other picture. Why is it 105? Is it 105 because of the pain? Is it 105 because they're septic and they're having chest pain from their endocarditis because they shot up with dirty needles?
Yeah.
And that's where the importance of the physical exam comes in. You listen, you hear those rubs, you hear those murmurs and everything. Oh, that's not good.
Yeah. Or if with nursing is make sure that for a blood pressure is make sure you have an appropriate size cuff.
That's huge.
Because that's the other thing, is it can be driven up. I've seen that.
I see it all the time, especially on a really big inmate, You get a guy who's 6'6" and 350 pounds, and he's got 19-inch arms, and they're putting an adult medium on him. His blood pressure is going to be 180 every day.
Right.
Yeah. It's not really. It's really 130. But because they've got way too small of a cuff, it's important that gets changed. Same thing for our little frail little lady. You put the adult large on her, it's going to give you artificially low readings.
Right. So equipment is important, and equipment that's calibrated also. Because sometimes you can have equipment that wherever, if you're and not calibrated, then if you're just using the automatic cuff, I think that sometimes they can be driven up with the automatic cuff. I think they tend to read higher, especially if they're not calibrated.
When somebody comes in, their pressure is high. Do you go and verify that yourself manually?
I usually just, where I'm at now, I just ask them. Where I've been previously, like if I'm out in the community or whatever, I'll just take it manually.
Yeah, I do too. I try to just check it myself.
Yeah. So, and do a manual. Although, I don't know if I hear the best either. So maybe, maybe that's, maybe the automatic one is a little bit more accurate. Don't know. But I guess the bottom line is for chest pain, each person that presents is going to be presenting differently. So I think you have to look at a risk stratification as to what are their
It's a differential.
yeah, I mean, what are their risk factors? Yeah. So sometimes I'll come in and then the nurses will say, well, it's not reproducible, whatever. I go and talk to the guy and he's done 500 push-ups.
Yep.
You ever have that?
A lot.
Yeah.
A lot. And in particular, kind of what he's mentioned before, that's that young guy that's complaining of chest pain. He's 24, whatever he is, and you go in and talk to him. He's like, yeah, man, I'm working out extra hard recently. And you're right. I mean, 500 push-ups is not unheard of. They don't have anything else to do.
Yeah.
Right.
They don't have anything else to do, and they want to look tough. And so they're definitely spending time push-ups and all kind of weird presses against their bunks or however they're doing it. One-hand yoga stands. I mean, they do everything to keep themselves in shape. And they will come in and definitely have that chest pain related to just extra activity.
I think probably the most important takeaway that I can think of as far as chest pain goes is to not get anchored.
Meaning
don't have an idea in your head already what it is and try to make the patient fit that idea. Because I've known 20-something-year-olds that have had heart attacks. It's a potential possibility. Sure, reproducibility is good to know, but don't say, oh, it is reproducible, therefore it cannot be a heart attack, or it is not reproducible, therefore it can't be musculoskeletal. Just don't get hung up on an idea. When you're building that differential in your head, don't decide it is this or it is not that. And when you start seeing evidence that contradicts your thinking, ignoring it. Because I do see people do that. Like, oh, it's not a dissection. I'm like, oh, their blood pressure is 190. No, he didn't say it was a tearing pain. He just said it was a dull pain that he didn't like. Yeah, but his blood pressure is 190. You can't get stuck on it. I mean, the only dissection that I'm aware of that we've had in jail since I've been there was the guy with the blood pressure of 120. I mean, nobody even ever would have thought of that.
Yeah.
right. Yeah. So any other comments about chest pain?
Chest pain gives me chest pain.
Yeah, it can give you chest pain.
It's I think for our setting, along with kind of head injuries, which we had before, it's one of the scarier things to deal with, just because the end result of not really paying attention to that can be very poor for the patient. So it makes it really, really important that we focus on it.
Right. And evaluation and management of rest of cardiac issues is can be difficult, but that's where a good physical exam comes in.
Difficult in all settings, but particularly challenging in correctional medicine.
Well, that's because you can't necessarily, you can send them to the ER, but like we've mentioned in previous podcasts, is that there's a whole line of things that have to happen with that. You can do it, but they have to be secured, and they have to go with somebody, et cetera, et cetera, et cetera. So, so the more that we could rule out on site, the better.
Yep.
So, any other comments? No?
Nope.
Okay.
That does it for me.
All right. So it's another episode of Off the Cuff Nurses, and we will see you next time.